Our next presenter, I've known her a long time. She was a fellow when I first started at UNM, and I credit her with a lot of mentorship when I was a young nurse practitioner. Dr. Ryann Bierer is an assistant professor in neonatology and pediatric palliative care at the University of Utah and Primary Children's Hospital. She completed medical school at the University of New Mexico in 2004, her residency in pediatrics at the University of Arizona in Tucson in 2007, and fellowship in neonatology at the University of New Mexico in 2010. She provides neonatology services at 3 facilities: the Neonatal Intensive Care Unit at University of Utah Hospital, Primary Children's Hospital, and Intermountain Medical Center. She then completed a fellowship in hospice and palliative medicine at the University of Utah in 2018, and now provides pediatric palliative care with the Rainbow Kids Palliative Care Team at Primary Children's Hospital, in addition to working in the NICU. I would like you all to join me in welcoming Dr. Bierer. It's so good to see you.
So good to see you, Brenda. Thank you so much. Such a kind introduction. And likewise, I feel like I learned so much from you and so much from a lot of people I think who are on this conference. I'm going to start sharing my screen. And let's see if this is going to work. We tried to do the run through. And so hopefully I share the screen that I mean to share. So while I sort this out, right now, will somebody tell me if you guys are seeing the speaker, the presenter view, or the slideshow view? Let's see, I'm going to try swapping them. Okay. What do you guys see right now? Just the slide, or do you see the presenter? Let's see. Presenter, yes, better. Great. Thank you. Thanks, Jen. Okay. Let me shut this. All right. And if there are things that you guys wanted to ask, I might be able to see the chat, but usually I can't during these talks, so I apologize in advance. Anyway, thanks so much for inviting me to be here. Really happy. I'm always excited to talk about these topics. It's definitely become my passion. And Brenda gave such a lovely introduction. There's a lot I don't need to say that she has already said. So what I was going to do today is just tell you a little bit about the work I do now, and hopefully provide some information about what perinatal palliative care is and palliative care in the NICU. I don't have any disclosures, and I thought I would just start with defining palliative care. This is, I guess, the definition that feels the most right to me. Palliative care is interdisciplinary care, and the goal really is to ease physical, emotional, and spiritual suffering of patients and their families from a life-limiting diagnosis all the way through death and bereavement. Palliative care teams look different in different settings. So teams may include providers, that can be physicians, nurse practitioners, PAs. Some teams have psychologists, social workers, nurses, case management, child life specialists, music therapists, and chaplains. And you can imagine, signal breaking up. Darn it. Sorry, guys. I'm going to try to get closer to my microphone and tell you right now that my office internet connection is kind of crummy, and I'm so sorry about this, but thanks for letting me know. Okay. Is it going to let me advance my slide? Let's see. There we go. I think sometimes when people hear palliative care, the immediate association is hospice. And a lot of people have typically heard of hospice, and maybe not as many people have heard of palliative care. So I do find it helpful to distinguish the two, and they are similar in a lot of ways. So it's not that that the association isn't warranted. So what they have in common are that they're both multidisciplinary teams with a focus on comfort, focusing on providing comfort, relieving symptom burden, and typically in a setting of a chronic life-limiting condition, or sometimes not chronic, sometimes it's an acute life-limiting condition. The primary difference is that you're referred to hospice if there's a suspected prognosis of less than 6 months. That actually has to be part of your diagnosis in order to qualify for hospice. And I would say hospice in general, most of the hospice teams I've worked with have more of a robust bereavement follow-up. Our palliative care team tries, but it's not quite as much of the focus as it is with hospice. And then you can be followed by a palliative care team, whether you are approaching your care with curative intent or not non-curative intent. Whereas if you're on hospice, it really is with non-curative intent. And what that means is, I think oncology, cancer is a perfect example where you will, you could be followed by a palliative care team who would be helping to support with symptom management. Maybe you're having a lot of troublesome symptoms with your chemotherapy, or with after your chemotherapy is stopped and you're having a lot of problems with weight loss or appetite or energy or things like that. The palliative care team may follow you for all of those things, all of that symptom support. Whereas if you've gotten to a point where you've been through chemotherapy and maybe it's gotten to the point where your cancer is not thought to be curable anymore, then you might be referred to hospice at that point. And so you wouldn't be continuing to seek chemotherapy. So I hope that kind of makes sense. As Brenda mentioned, I work with a team called the Rainbow Kids Palliative Care Team at Primary Children's, and you can see the makeup of our team currently. It's definitely a growing team, and that's really to try to meet the needs that we have in our hospital. And I will say right now, we're always busy, so we don't often feel like we're ever fully staffed. The physicians all rotate for a week at a time, but everyone else listed here is their full-time or maybe part-time kind of split positions. But it's a really robust team, and I'm really grateful for it because we do have a child life specialist who's trained specifically in palliative care, our chaplain who has a ton of experience in hospice and palliative care, our social worker, and everybody can really help support the families from every component of their lives. So perinatal palliative care is a somewhat more recent, I guess, distinction or field of care. And it refers to a coordinated care strategy that comprises options for both obstetric and newborn care. Again, focusing on maximizing quality of life and comfort for newborns that might have a life-limiting condition. So this is from the ACOG statement. Like I said, it's relatively recent, from 2019. I was going to talk a little bit about what we do with our team when we have a perinatal palliative care consultation. And we have a fetal center that has really become pretty robust in the past 3 to 4 years. And it's a physical clinic here at the Children's Hospital where pregnant moms are referred if they've had imaging or prenatal testing that indicates that their baby's going to have some condition that's going to require some care afterwards. And that could be, it's a wide range. So some of it is for surgical indications, things like gastroschisis and omphalocele and congenital diaphragmatic hernia, but sometimes it's for conditions that there is a concern that it might be a life-limiting condition. So that could be trisomy 18, trisomy 13, it could be anencephaly, things like that. So we are asked to come meet with families if there is a concern that they're either going to have a life-limiting condition or maybe really complex medical management decision-making, I guess I would say. And a perfect example is we have a baby mom's pregnant with a fetus with a very complex neurologic malformation who also has a large right congenital diaphragmatic hernia. And so it's walking through all the different information they're getting and then helping them decide what care they want to pursue or not pursue for their baby after they're born. So during that consultation, our first steps are just to introduce palliative care, talk about the concepts of palliative care, talk about what hospice support is. We do have a nice link for hospice in that most of the physicians who are on the palliative care team are also the pediatric hospice attendings. And so we have that sort of connection, I guess I would say. And we work with a lot of the hospice teams, even if they're not local. We have worked with hospice teams in other areas, even Idaho and Wyoming, teams that might take care of these families and these babies after they're born, if they survive to leave the hospital. We really want to start during our consultation with learning about the family. We want to hear about the parents, who they are, sometimes even how they met, how long have you been married? What does life look like for you guys right now? Are there other siblings? Where do you live? Do you have extended family and friends? Is that supportive or not supportive? We all sometimes have family who's not as supportive. We talk about their employment, and do they have employers who understand that they might have a big event coming up with their child being born with a condition that could be pretty complex. And it also leads into financial concerns, which I think is very important to address as well. And then spirituality can sometimes be a big source of support for families, so we explore that with them. Sometimes there are also families who are experiencing spiritual distress, and that's another place where our chaplain can be really helpful for families. One of the primary goals of our consultation, I would say, is to help delineate the goals of care. And this is tricky because I don't think anybody comes into the room knowing exactly what their goals of care are. Or if somebody asked, what are your goals of care? It's such a vague concept. So instead, what we try to do is learn about who this family is. What do they enjoy doing as a family? What makes a good day in their lives? And what do they consider to be a good quality of life for their unborn child, for their other children, for them as a family? And the thing is it looks different for every family. So there's no way to know for sure what one family would say versus another about, I would or wouldn't want this for my child. You may have one family who's very active. They love to go camping. They like to go hiking. And the idea of a child being fully supported by all medical technology and not able to leave the house other than maybe just to get to doctor's appointments doesn't feel like a good quality of life for them. Whereas another family might feel that any time with their child alive is good time for them, and that they would be willing to accept technology dependence if it meant that they had more time with their child. But again, we don't know that unless we learn about the family. So we do spend the majority of our time just getting to know the family themselves. And then we try to provide support in medical decision-making based on those goals of care that we help them identify. The team also will do our best to coordinate with the delivery providers, as well as follow-up pediatricians and maybe the hospice team. And this is all around the delivery planning and what care parents do or don't want after delivery, to hopefully minimize all of the questions that they might be facing when the baby's born. What do you want? What don't you want? If we can have those discussions in advance when things are cool and calm and parents aren't under distress and mom's not in pain, then hopefully they can get a better idea of how to plan for their baby's delivery. We definitely offer sibling support with our child life specialist. And oftentimes that's a phone call, but typically it's helpful for parents to just hear, different kids at different developmental stages. What do I tell them? How do we talk to them about this? How would it be if they bring the baby home and they die at home and my other children see that? So she really can talk through these things with the parents. And then definitely we involve our chaplain if we feel like spiritual support would be helpful for them in the prenatal or perinatal period. When we talk about decision-making, again, we always try to tie it back to what the goals are for this family. But we also know that there are so many factors that go into how families make a decision. And I've already alluded to a lot of these, but just making sure that we've really explored each of these in depth, I think is really important. So their personal values, influence of family or friends, that can be pretty big. We might have parents saying one thing and we might have grandparents influencing in other directions. And so we need to suss that out for them and help support them through that. Spirituality and faith, their own hopes and fears, any financial considerations, and definitely prior experiences. Sometimes families have had significant experiences that make them, that will definitely color their perceptions of how this goes. Sorry, and my slide just jumped. I apologize for that. When we meet with families, we do try to start at the beginning, and especially we like to hear what they've heard or what they understand so far about their child. And I try to make sure this doesn't feel like we're quizzing them or that they should know more than they do. I try to paint this as the medical providers may have felt like they were providing the family. We say it all the time. We know what we've told parents, but we don't necessarily know what they've heard or understood. And so this is just an opportunity to really hear what they get so far, what they understand or don't understand so far, and make sure that we can fill in any knowledge gaps if we can. If there's things that, oh, I've heard this, but I didn't quite understand what it meant. Either if we can't fill in those gaps, then we try to find the people who can. So we do want to know what the previous discussions, like who was involved in those discussions? Were both parents present? Was it just mom who was overwhelmed and hearing all this information and maybe absorbed 5 seconds of it? Sorry, guys, this seems to be on its own little timing thing here, which is real fun. So I'm going to go back to this and see if we can make that not happen again. So I do like to hear who was involved in those discussions, not only from the parents and their support system, but also what providers that they met with. So if they have already spoken to cardiology, but it's going to be a complex heart surgery, have they talked to the CT surgeons? And do we know for sure what that they're getting the answers from the people who can provide the accurate information? Or have we left gaps? Are there big important pieces? Oh, they haven't actually talked to a neurosurgeon yet when they're hearing about my baby might need a shunt and might have prolonged complications with shunt infections, et cetera. And then we definitely want to know if there are any unanswered questions and where we can try to help fill in, like I said, any knowledge gaps if there are any. Then now it doesn't want to move forward. Let's try it again. There we go. One thing that I do try to acknowledge, and I wouldn't say emphasize, but definitely just try to make sure people are aware, is that we're asking a lot of parents to make decisions in the prenatal period when there's a lot of prognostic uncertainty. And I think we have this blessing and curse of additional ultrasounds and MRIs and a lot of information that parents are getting and the medical team is getting prenatally. We know a lot about the anatomy of these babies, or we think we do, before they're born. And then we're asking parents to make decisions based on things they haven't even met their baby yet. They haven't even seen them in person. And we know that there's sometimes the things that they find on ultrasound and the baby's born, and we're like, oh, it's either not as bad as we thought, or it's something else entirely. And we didn't even know that that was going to be the case until the baby was born. So I think it's really important to remain sensitive to that. I think sometimes I've in the past felt frustrated with families if they if it felt like they were wishy-washy about their decision making or didn't know how to proceed. But then if we take into account that this is hard anyway, making decisions about the care of your child after they're born is incredibly difficult. And then we add on that the layer of sometimes incomplete information or prognostic uncertainty, it makes it that much harder for them. And I also really try to emphasize that it's okay if our decisions change after birth. And I think that can be really hard for people because they think, well, we're they said comfort care, and now the parents are saying they want us to do things, and we've lost all this time and this potential time. But I think that if, as much as we can, support the fact that their decision making may change after they've met their baby, and all we can do is try to support them as best we can and provide as much information as we can about what these decisions may mean moving forward. This is sort of some verbiage I tend to use. And again, this is just to try to normalize this for families. So I will often say some families choose to focus on comfort and forego interventions that can cause pain, suffering, or separate your infant or your baby from you. Some families may choose to attempt all life-prolonging interventions because their goal is having more time with their infant alive. And some families choose something maybe more in the middle, where they might want to attempt an initial resuscitation, but then have subsequent reevaluation to decide on what the next best steps are for their baby. And most importantly, I try to emphasize there are no right or wrong decisions. These are decisions guided by your goals as the loving parents you are. When we do talk about decision-making, we do go a little further, talking about labor management. And sometimes these conversations have already come up between the mom and her, or the parents and their provider, their OB or MFM provider. But if they haven't, I feel like it's helpful sometimes to start the conversation so they've thought about it ahead of time. Do they want fetal monitoring during labor? And if so, what kind of monitoring do they want? Do they want continuous monitoring? Would they want intermittent? Do they not want any monitoring at all? And what does that mean? If you've got continuous monitoring, then you're connected to the wires the whole time and you're hearing the beeps going the whole time. And for some families, that's reassuring because it's more information. And for some families, that's just more stress and angst inducing. And then additionally, would they want to be notified if the baby died before delivery? And these are personal questions, but it's helpful for the medical team to know ahead of time going into the delivery what parents would desire. And then I do talk about mode of delivery because I try to spell out that in a situation where you didn't have a life-limiting condition, if there was evidence of fetal distress, the standard of care might be to proceed to a C-section. But as we know, a C-section can have a lot of implications for maternal health, recovering from a surgery, her future, reproductive health. And in a worst case scenario, an emergent C-section might mean that mom needs general anesthesia and she might not be awake when her baby is born. And if her baby is going to only live for a few minutes, that could impair any bonding time the mom may have with the baby. And so talking about these things ahead of time and then hopefully clearly delineating in the delivery plan what the parents would or wouldn't want helps provide the medical team some reassurance that they know how to proceed and that this, we might not respond to fetal distress. It might just be a C-section for maternal indications, for example. And I saw a question in the chat. It's a big, heavy question. I'll try to save it to the end, and it's about fetal care. So I did see that. I'll try to address that as we go through. Around resuscitation, again, sometimes this can be a little tricky, but in general, we try to identify, do you want the baby transferred to the NICU for a resuscitation attempt? Do you want them to remain in the room with you? Do you want initial stabilization to provide some time to gather additional information? And we'll even talk about sometimes parents have opted to say, we want the baby to be brought to the NICU to stabilize because we know mom has to have a C-section and we want to get her through her not full recovery period, but the initial minutes where they have to sew her back up and get her stabilized before they then have time for mom to come meet the baby. And then they might redirect the care to, begin removing the life-sustaining treatments. And then are there interventions that they would not want attempted? So painful interventions like chest compressions or chest tube placement, parents may say, we would be okay with some of these initial steps, but if it looked like the baby was going to need chest compressions or something painful, we wouldn't want that for them. We would just want the medical team to tell us what was going on. After delivery, sort of goals during and after delivery, it's helpful to know who they want in the room during labor. And if there are any people in particular that they would like present, and do we need to if we can, make exceptions for them on labor and delivery. And I know this all got changed during COVID, but if there are siblings that can come either during labor or after delivery, spiritual care providers, especially if there are any specific spiritual practices that they desire around the time of birth or after, and then who's going to be in the room during the actual delivery. We try to go into that as much as we can. And it very much starts to sound like a birth plan. And I will tell you, with my neonatologist hat on, I know the resistance to birth plan, but this is something that I do think families find to be a source of support, is kind of knowing ahead of time who's going to be in the room during the delivery, and are there things that are going to make this as meaningful as possible for them. So then we try to summarize all of this, their goals, the plan before, during, and after the birth of their infant, and then complete that delivery plan and provide copies both to the parents as well as trying to enter it into our medical record if we know that they're going to be delivering in between one of our two institutions. And then we do try to follow up again with the referring providers as much as we can to review the delivery plan. And if they are hoping to deliver maybe close to home at a smaller hospital, we try to check in with the team there and review, are there any concerns with this plan, or Are there any questions, or how can we support? And is everybody prepared for when this family comes in? And really, that's everybody is typically so accommodating when they know that this is a very, these are extenuating circumstances for this family. I do try to go through the symptoms to expect at end of life. And I do this both with the family, I ask permission if they want to hear about this. I also will sometimes mention this to the teams who might be taking care of the baby after they're born. And this applies obviously to the NICU if the baby's dying in the NICU as well. Just to kind of have some advanced warning of what they may or may not see. So their skin may change, and this might be mottling. It might be changes in color, sometimes dusky, sometimes pale. They might become cool. Their extremities might become cool before the rest of them starts to get cooler. And all of that can happen while the baby's still breathing and still has a heart rate. And then I talk about breathing changes and try to prepare that there might be longer and longer pauses in between their breaths, and that those breaths might begin to sound more like gasping breaths. And that's a normal change in their breathing at the end of life. And that they might hear gurgling or secretions. It sounds like secretions. We do talk through a little bit of, and I'll mention this in my next slide, but sometimes people feel inclined to want to suction if they hear those secretions as their breathing begins to change. And we just try to warn that we might have an unintended consequence of causing more agitation if we try to suck out the secretions in the back of their throat. That might actually be more agitating to the baby or to a patient. If we can just accept that the gurgling and the secretions is kind of a normal part of like your body, you're not swallowing like you do. And this is a natural part of the last minutes and hours of your life. And then neurologic changes that they might expect, that could be irritability or agitation, possibly seizures. I tend to see the babies just seem to get sleepier, if anything. But certainly we want to warn parents that if any of these things occur, we do have things we can provide to keep them comfortable. And so we do provide comfort measures and recommendations in our delivery plan notes that we provide with our palliative deliveries. So this can include skin to skin time, both with mom or dad or both, warm blankets, hats, anything, or a hat for the baby, anything that's going to keep that baby more comfortable. And again, just focusing on their comfort. If there are breathing changes, if there's that gurgling in their throat, you can try repositioning the baby. And again, I mentioned suctioning. I think that's something to be considered, but with the understanding that it might actually cause a little bit of discomfort or agitation. Oxygen is tricky because some families think as they see the color change in their skin that they want to, or some providers might feel like, oh, should we give oxygen? And I try to reassure that I don't think people, in general, we know patients aren't more comfortable if they're receiving oxygen at the end of their life. They don't experience less of that air hunger. There are other things to address air hunger, but just regular oxygen doesn't actually address that. Whereas something like morphine does. Morphine can actually address that sense of air hunger or breathlessness. And so we talk through if parents or the medical staff get a sense that the baby is having, whether you want to call it dyspnea or air hunger or breathlessness, whatever, any sort of distress in their breathing, you can provide morphine. And this is kind of a middle of the road dose, 0.1 to 0.2 mg per kilo. Some will even do a little bit more, but it's a relatively low dose. So I reassure parents, this isn't going to necessarily, it's not given with the intent to stop their breathing. It's given with the intent to make them more comfortable as their body transitions. And so that can be provided orally or sublingually, just with a little syringe that can be squirted into their cheek. It absorbs under the tongue and can be provided as often as they feel like that symptom is occurring. And we say like every 30 minutes, but I will say in the hospice setting, we can provide morphine more often than that if we feel like there are symptoms that we truly haven't managed yet. And then the last section, sorry, I just opened the chat and now y'all are looking at it too. Here we go. The last section is for any sort of neurologic, like if they're agitated or uncomfortable, we do talk about feeding for comfort. And this gets into a whole other conversation. I didn't really have time to put into this, but we do talk to parents. Sometimes, moms may have wanted to breastfeed before they knew that their baby was going to have these conditions. And we say, you can still consider putting baby to breast for comfort if you feel like the baby is showing cues, acting like rooting around, acting like they might want to go to breast. We definitely start to get into some more complex conversations if the parents ask about, well, would I continue providing like tube feedings for my baby if they were still alive 2 or 3 days later? And how could I not feed my baby? And am I starving my baby? And so we get more into the conversations of as a baby and anybody is approaching the end of their life, their body's kind of shutting down. And providing food can actually, like forcing food on them basically, which is what you would do with tube feeding in a dying baby, might actually be causing more discomfort than comfort. So with that reassurance, hopefully we can get parents to a place of, if the baby wants to try to breastfeed and is showing cues, go for it. If that feels good for you and feels like it's providing comfort for your baby, go for it. But then talking through the feeding that's not requested by baby. And then lorazepam is definitely provided for any sort of seizure activity, obviously, but any agitation too. We just try to reassure parents that that can be given as well. And then morphine can definitely be provided for pain if the parents do feel like there's a source of pain, which could be in a set, like for maybe our severely hydropic babies, that they just seem generally uncomfortable. We can provide, and it's the same dose. Okay, so that was the first part of it. And I can't tell if I'm talking too fast or not fast enough, but I think I can keep going. So the second half of my talk was, I wanted to talk about perinatal palliative care and sort of how we approach it or how I've approached it so far. But I also thought talking about palliative care in the NICU in part felt like, well, I think we already do a lot of palliative care in the NICU. I don't know that talking through the technicalities and some of the things we just talked about, symptom management at the end of life, those are things that are already done in the NICU. What I did find really interesting when I came across this article is about communication in the NICU. And I really liked this because when I did my palliative care fellowship, I discovered that probably one of the largest components of my training was really in communication skills and how we choose our words and how we talk to families in ways that can either alienate them or can actually create stronger bonds and trust. And this article, I felt like just hit the nail on the head with a lot of the opportunities I think we have in the NICU to approach our communication with the families. So these authors kind of broke it down into 3 topics, and I'm just going to go through each of them. And the first one is everything. I don't know that anyone hasn't heard something along these lines, but I'll read this. We want everything done. A 35-year-old G1 pregnant woman with no significant medical history is about to give birth to a term infant with known trisomy 13 and complex congenital heart disease. The neonatologist, never having met the woman, wants to determine her goals of care for her neonate. The neonatologist counsels her about outcomes of neonates born with trisomy 13. She tearfully looks up at the neonatologist and says, "Please do everything for my baby." And I think many people, myself included, have heard parents say something along those lines. So I hope this doesn't offend anybody. But when I hear something like that, it makes me squirm inside. And so when you hear something like that, I would just ask you to consider, how squirmy does it make you feel? And these were just pictures I found on the internet of things that definitely made me feel squirmy. So when you hear a family say, "We want everything done," I think it's a good time to do a self-check of like, am I feeling uncomfortable with that? Is it making me squirm inside? So what does it really mean? When parents say we want everything done, what we know is that it is all emotion. It is completely emotionally laden. And recognizing that, as opposed to imagining that they know all the technology that could be used, just going back to, oh, wait, there's actually emotion here that we need to address first. And also acknowledging that the context is nearly as varied as the possible meanings. What everything means to one family could be completely different from what everything means to another family. And until we've explored that, we just don't know how to support this family. So we do know that we hear everything in a lot of our day-to-day messaging between ourselves and, physician to physician, nurse to nurse. This family wants everything. And I think sometimes that carries with it a little bit of our own biases about what this family is or isn't deciding. And sometimes we haven't actually explored what they mean when they say everything. Sometimes we have, and it's hard when we think that they are doing things to their child that we don't agree with or we think are causing suffering. And we try to work through that with the family and really understand what everything means to them. And I think this was probably a very helpful thing for me to read in this article, was that there really is a fear of abandonment at the base of this. And it's because we have sort of this binary view in medicine of, well, if you're not doing everything, you're doing nothing. And so when we say everything, it really is like, well, we can't not do things for my baby. And so I think that was really helpful for me to kind of step back and realize families, they may not actually feel like doing everything for my child, but they might feel like if I didn't, then that means that I've given up on my child or family member. And what does that say about me as a parent? How could I be a loving parent if I'm not asking the team to do everything for my child? And this just kind of goes into more details. So they may not actually want all the procedures that we could do. They're really unlikely to actually benefit the length or quality of their lives, and probably would just cause pain or suffering. But they would prefer this over any perception that they are abandoning their child or that their child's care is being abandoned by the medical team. So the ironic thing is that the perceptions can become increasingly divergent and the polarization can feed on itself. So the family might become more vocal or agitated. I would say they almost dig in their heels more about wanting everything, while the medical care team is becoming more frustrated with the family for fighting for futile care. So the more the medical team is like, I can't believe they're doing this. What are they doing? Even if we're not saying that out loud to the parents, people pick up on that energy, and they might just, again, dig in their heels more and feel, because they are fearing that abandonment. So really, if we step back and think about it, the family has one short-term priority. They don't want their child to die. And when we say, I want everything done, it's because they don't want the alternative. So this can really be a plea to avoid the finality of death. And like I started with, it's an emotional appeal for support rather than a cognitive request for therapeutic measures. They're not saying, I want everything. I want you to put in tubes and lines and needles and everything. It really is an emotional appeal. So I really liked this, and I'll talk through it a little bit. The physician says, unfortunately, your child isn't responding to the treatment as we had hoped. The parent says, we want you to do everything. And the physician replies, it is so scary to think he may not survive this. You have been such a loving parent through this time. I wonder if you would be willing to share with me what you were hoping for. And so there's three parts to this, and each one specifically are really powerful. The first is that they acknowledge the emotion. It is so scary to think he may not survive this. And I do this all the time, and I teach our fellows all the time. As soon as you recognize emotion, I think we as people tend to shut down, look away from it. Oh no, this is scary to be in the presence of somebody else's emotion. The first thing you can try to do is just name it. And sometimes naming the emotion that you think is probably present can de-escalate things dramatically. So if you can imagine a parent who's angry and, how could you not be doing this, everything for my child? Turning back around and saying, this can be such a scary time, or I can't imagine how difficult this is, or I can't imagine how sad you must be, or so many parents have found this to be such an incredibly scary time. Just saying the name of the emotion out loud. And sometimes I'll tell people, sometimes I don't get it right. Sometimes they say, this has got to be so scary. And they'll say, no, I'm angry. I am pissed. This is not fair. This shouldn't have happened to me. But at least then they've been able to acknowledge the emotion, and what's backing up their behavior, what's behind it. And then the second sentence in this is acknowledging and respecting them as parents. And that I found goes really far in the NICU. Being able to tell parents, you've made You have been amazing parents through all of this. You clearly love your child so much. You are such an advocate for your child. No matter what the decisions they're making, I try to respect that they are making the decisions that they feel are best for their child. And then the third one is exploring. And I love exploring. Anytime I feel confused or stumped with an interaction, we have a favorite phrase that we use all the time: tell me more. And that's what this third sentence is. I wonder if you would be willing to share with me what you're hoping for. It's simple as tell me more. So if somebody says, I want you to do everything, you can start with tell me more. What does everything mean to you? And that can open up like a better understanding of where the parents are really coming from. Let's see, making sure I'm not missing something in the chat here. Now it's not letting me advance. Sorry, guys. We'll get there. There we go. So I do like the idea that everything can be treated as an opportunity to explore their values, their emotions, their biases, and ultimately what the goals are that they are developing for their child. So the second one is hope. And I think this can be an equally, it can stir things up for me as well. We are hoping for a miracle. The physician says, how are you and your son today? The family replies, we're doing okay. We just spent most of the time praying. We are hoping for a miracle. And again, I try to do a self-check. How squirmy is this making me feel? And some people will say, if you personally are more religious or share a religious or a faith or something, and somebody says they're praying, maybe you're less uncomfortable with it. But I think this idea of like, oh crap, they're hoping for something and I don't know if we can meet their hopes. So another component of hope in the NICU is I don't want to take away their hope. And I think we do this all the time without even really realizing it. And it comes from a very good place. But how many times have we said something like this? Your child was without oxygen for a long time and her brain was likely damaged. Is it permanent? Not necessarily. And the other organs are working well, which is encouraging, right? Like we want to also be hopeful and sometimes at the expense of providing our honest assessment. So I think hope can be, there's a lot of it in the NICU in different ways. Again, hope is varied and highly personal. And in medical care in general, I think people hope to return to a previous state of health. So if somebody comes to the hospital, they're sick, they're hoping that somebody in the hospital is going to be able to take care of them, fix them, make them better, and they'll get back to their previous state of health. It's a little different in the NICU because all of our care is framed around hope for a future. These babies didn't have a life typically before they got to the NICU other than inside mom. So everything is framed around what they hoped for this baby, for their future. I do think hope informs the medical updates that we provide and can also be at the center of how each family processes medical information. Just reflecting on this, I can't count the number of medical updates I've provided to parents, and it's all focused around the hope. Like, the baby's doing well. He tolerated our feeding advance today. And he stooled, so we think we're going to be able to go up a little bit faster. Those sorts of things are all based in hope, which is, I think, a very natural place for people to provide medical updates. And then parents also hear that and process it from a place of hope. So where it gets tricky is if we start to feel that the family is maintaining hope, but the evidence is speaking against that, and they feel like the family isn't getting it. And I think that that's something I've run into many times. Oh, they just don't get it. They don't understand. We're trying to tell them again and again. And the team might want to avoid giving false hope so that we feel reassured that the family can make appropriate decisions about their goals of care and so that they can process the difficult road ahead. What I have seen, and I try to identify it and hopefully mitigate it, is sometimes we get so intent on this family doesn't get it. They need to get it. Somebody else has tried to explain it. It didn't get through. Maybe I can explain it in a way that they'll actually get it and make a different decision for their baby. And then each team member that comes along and tries to do that, you end up just beating the family over the head again and again with all this difficult, painful news that, and all the family perceive is that they're trying to take away our hope. They're trying to convince us to give up on our babies. And again, it can create that sort of animosity and can decrease the trust in the medical team. And so I really liked this statement: acceptance cannot be done to or for the patient. The patient must do it. And in this case, the parents. We can't force the parents into acceptance. They have to get there on their own. And all we can do is try to be there to support them. So I do think good communication of medical information allows for hope and builds trust between the physicians and the families. And one of my favorite phrases is, I hope, blank, I worry, blank. And so I hope that your baby proves us all wrong and doesn't need to be intubated and is able to grow and leave this NICU. I worry that if things continue to get worse, we could have only a short time left here with your baby, and we want to optimize the time we have. I hope and I worry. And it's really helpful, I found, to align us with the families, and they still feel like we hope with them, and that we're also able to be honest with them about what our worries are. So this is from the paper, but similar. So given this new information from the MRI, I'm wondering, what is it that you're hoping for? Family says, we are hoping she will get better. The physician said, it's obvious you love her very much, which is a nice respecting statement. I'm hoping for the same thing. What else are you hoping for? And that can be, again, just exploring more. And I would also offer, if they share more of things they're hoping for, you can continue. Gosh, I really hope that's what happens. We all do. None of us came to medicine to want to see babies suffer or want to see babies die. We are all hoping for the same thing. I worry that this could mean X, Y, and Z. And then my last one, and then I'm almost to the end, is withdrawal. So I think I trained, and throughout all of my training and everywhere in every ICU I've ever walked into, we talk about withdrawal of support. And it's part of our vernacular: withdrawal of care, withdrawal of support. The parents are going to withdraw. It's nice to remember that the family and parents, the loved ones, are going to remember details of the death. And this includes phrases that we use so commonly that we don't even recognize the power that those phrases can have. And there's something that I think can be felt when they hear withdrawal of care, is that we are withdrawing from their loved one, right? We're pulling care away. We're going to abandon them. We're going to step back. We're going to stop taking care of it's kind of that dichotomy thing of like, we're either doing everything or we're doing nothing. And so withdrawal of care can kind of reinforce that feeling of like, oh, wait, they're not going to support us anymore. And even if they can't say it, it's just our phrases sometimes, I think, can cause harm, I would say, that the parents could live with for the rest of their lives, feeling like they withdrew or the team abandoned their baby. So fear of abandonment at the end of life by medical team, it's a big thing. And I think there are alternate phrases that can be used. The one I've tended to use the most is redirection of care. And an example of this, I will say, if things aren't going well, we will look at redirecting our care to focus on the baby's comfort. Or this family has opted to redirect care and forego artificial life-sustaining treatments. Or you can say stop artificial life-sustaining treatments. If we're saying they're going to extubate the baby, then we are removing an artificial life-sustaining treatment. But it's only because we're redirecting care, not because we're withdrawing. We're just redirecting our focus. And we get to now focus on only doing the things that keep the baby comfortable and keep the family supported and provide time for whatever memory making or any things that can help them have the best possible of a really crappy experience. So that's it. And I definitely would love questions. I'd love this to be as conversational as possible, even though I know it's Zoom. Yeah, I love that. IUGR, growth retardation, somebody asking if that meant her baby was retarded. And of course, like, we use so many words. I mean, the first year of medical school, I feel like, is a language school more than anything else. We use all these words that are only medical words and aren't part of our English language normally. And so then people are going to understand things differently than we intended. And that's why I come back to what we think we've said to parents can be very different from what was actually heard or perceived. And it's really helpful to know where the mismatches occurred. And I think that's it.
Ryann, thank you so much for coming and joining us today. We missed you quite a lot. Does anybody else have any other questions for Ryann before we let her go for the day? I think that's it. Ryann, have a great afternoon. I hope it's warmish there.
It's not, but that's okay. At least we have a lot of snow to play in. If it's going to be cold, at least you have snow to play in. So
exactly. Nothing makes me more grumpy than cold, sunny days. I'm like, at least get some weather. So that's
yeah.
All right, everybody.